Welcome to my
relatively
world.
lucky. No, I've had
Yeah.
4 eyesight since
Is
I
that
was
right?
little.
You know, we don't bite if you want to move closer to us. It's a big room for a small audience. So, of course, every time I say that, nobody moves anyway. But if you're interested, come forward. We're nice people, right? At least we used to be. We'll start in just a few minutes. We have the unenviable position of being right after lunch. Not a good place. The postprandial pause, I guess you call it.
Oh, right, that's what happened.
Yeah. And you did all that preparation? I think we're going to start on time. Are you guys up for that? Okay. Yeah, let's reward the good students. Right. Oh, no worries, no worries. Yeah. Thank you for saying that to Martha, Merrill. That was so kind of you, yeah. It's true, it's true. It needed to get said, so. I was applauding you as much as her. Well, as you can see, we're a rather informal lot. If you want to move forward, that would help us a little bit, perhaps. Otherwise, we're going to get closer and closer to the microphone to get louder. And we're not going to wait because I believe in rewarding people who are on time. So thank you all for showing up. The better professionals got here on time. I also would like to begin by dispelling rumors that I have multiple personality disorder. There actually are 3 Russells at the APSARD meeting and who have worked for decades in ADHD. Obviously myself, Russ Shacker, and Russ Ramsey. But I thought we've all been asked to sign each other's books and autograph things that belong to the other person, and we'd like you to stop it, right? So, the title of our program is The Promise and Perils of Evidence-Based Treatments for ADHD. We are going to spend the majority of our time on the perils. That's really the intent and focus of this. I don't think we need to promote the effectiveness or efficacy of these treatments. They have been promoted in hundreds of scientific studies, in many sessions at not only APSARD but other scientific and professional meetings. So we will pay brief homage to the fact that all of these treatments are effective and successful, hopefully for a majority of our patients. The real purpose of our submission to APSARD to do this program was to focus on the much overlooked area of adverse events that occur with the evidence-based psychosocial treatments, and then to talk about where we think things need to go within our respective areas of treatment specialization. So I'm joined today by several fine professors, and being professors away from home, we all have more slides than we should, and you'll be subjected to that as we go. And I will follow the Joel Nigg school of presentation, and that is I won't eliminate my slides, I'll just talk faster, which I do already anyway. Just so you can get past the business part of this is my disclosure statement. This is where I've received income for the previous 12 months. I should also put up there that I do get Social Security and a pension from the state of Massachusetts. So I am heavily conflicted with federal and state pension programs. So, not to mention all of these other things. But Steve Ferrone and I, for many years, have tried to promote the idea that speakers need to disclose all sources of support, not just pharma support. Otherwise, it's very, I think, hypocritical to do otherwise. So that's why the slide is a bit busy, and you can see that I've been a busy boy for the past 12 months. The idea for this presentation, or this program submission, came from two special issues that I commissioned last year for the ADHD report dealing with adverse events in evidence-based treatments for child, adolescent, and adult ADHD. And the reason I did that is because it was becoming increasingly obvious, and has for more than a decade, that researchers working in psychosocial treatment for ADHD were not studying side effects at all, and were behaving as if there were none, when in fact those of us who have been in the field long enough to have implemented these procedures across hundreds, if not thousands of cases, know full well that the opposite is the case. But I do want to draw your attention to the February and March issue of the ADHD report, in which we covered all of these treatments, each article written by an expert in the treatment on the adverse events that were likely to be seen with every one of these interventions. This is a one-of-a-kind resource. I've never seen anything like this anywhere in ADHD, but I highly recommend that you read it if you are engaging in any of these psychosocial programs in your clinical practice. Instead of focusing on all of those, as we don't have enough time in 2 hours, I selected what I thought were the 3 most evidence-based, non-medical interventions to concentrate on in our symposium. So we're going to be speaking about behavioral parent training, and to some extent behavior family therapy for teens, though that is a far less evidence-based approach than behavior management training is for parents. Also, Linda Pfeiffer is going to speak to us next on classroom behavior modification methods. And then finally, Laura Naus, an expert in cognitive behavioral therapy, will talk to us about its application with adults and the kinds of adverse events and side effects we might see there. All of us readily acknowledge the effectiveness, the efficacy of these 3 interventions. They're widely documented across many studies and now meta-analyses of these treatments, so there is no question of their utility. So please do not think that we are here to beat up on the psychosocial interventions. We're not. We are all psychologists, which I thought was rather ironic, that we would be the ones to call attention to our own field's blind spots when it comes to treatment and treatment research. Now, unfortunately, I think Alan Schwartz from the New York Times must have gotten hold of the printing company that did the program, because I just noticed this morning that I'm not in the program, right? Even though I'm the first presenter. So I will be speaking first on behavior management training for families, and then we'll follow up with the other 2. In case you're not familiar with Alan, he raided this conference 3 or 4 years ago, is largely responsible for the increase in security around our meeting, and went on to publish a number of critical articles against ADHD, including the book ADHD Nation, which also a critical account. So hence my sentiment about Alan. So we have known that there are adverse events associated with all psychosocial treatment for at least 50 years or longer. And I will just highlight a few of the findings that go back into the 1970s with regard to a variety of psychosocial interventions that were being used in psychology and psychiatry. And I won't read these to you, but you can clearly see that many forms of therapy, clinicians were beginning to report that there were adverse events among subsets of their population that they were studying. So there is a long history of reporting on adverse events associated with these treatments, at least in the broader field of psychotherapy. This is also true of systematic desensitization for anxiety disorders, which has been shown to also increase anxiety in a subset of patients. And behavioral parent training for families was documented even in 1973 to produce an increase in disruptive behavior in a subset of the children whose parents were undergoing some of the initial prototypes of behavior management training for families. Overall, it's been estimated by various writers over the years that at least 5 to 10% of adults who are in randomized controlled trials, bear in mind that they are highly screened individuals, and as many as 14% of people receiving routine care are likely to show deterioration in their treatment endpoints. That is, whatever the goal of treatment is to resolve, they are getting worse rather than better. And more recent papers have shown that children are probably even worse. That is, a higher percentage of children are likely to demonstrate adverse reactions to psychosocial treatments. In these studies, 14 to 24%. So we are in good company in believing that ADHD treatments that are non-medical must have adverse events associated with them, even if nobody talks about them. And that is what we choose to do here. So why have clinicians and clinical researchers across other specialties and disorders failed to report systematically on the side effects of their interventions the way we compel studies of psychopharmacology to do likewise? Well, one belief was that in the early years of the psychotherapies, they simply didn't work. So there was very little impetus to study adverse events because nobody thought that they were anything other than perhaps benign, maybe mildly effective interventions. However, that course began to change as investigators began to develop much more effective interventions, the behavioral interventions in general, cognitive behavioral and behavior modification interventions specifically, as evidence began to accrue that these were powerful and effective medications for a large subset of people to whom they were being applied. We began to see people starting to report side effects of these interventions. But again, these were very casual clinic observations. If they were ever put into articles, you have to dig deeply into the methodology to find even a passing reference to a problem that the individuals might have had. A second reason, I think, why we don't see a lot of reporting of this is that among psychotherapists anyway, it is believed to be evidence of bad practice that you would even have adverse events. It is a reflection on your skill, on your talent, on your expertise, because after all, if you are expert in this form of psychosocial treatment, you shouldn't be having side effects. So in essence, it's the sort of don't look, don't tell attitude toward your patient population. Then there are other studies that have come forward to indicate that clinicians are extremely inaccurate in reporting who in their practice is likely to be deteriorating. And as evidence of that, you can see Hannon's paper here, in which they were tracking all patients in this randomized controlled trial. They had 40 people show marked statistically significant deterioration as a result of the trial. The psychotherapists involved in the trial reported 3. So they can't even detect 10% of the individuals who are actually systematically deteriorating as a result of the trial. And then, of course, there is the lack of training. I know when I went through graduate school, I'm sure it was the case with my colleagues here, that we were not trained in adverse events within our particular methods and practices. Or if we were, it was probably by a senior elder statesman of the field, but it certainly wasn't part of the manuals, wasn't part of our formal training or our coursework to go looking for adverse events. So we have a couple of problems here. We have the lack of training, we have the inaccuracy of clinical opinion, we have, of course, confirmation bias, that we cherry pick only the positive results and ignore the negative results. But for a variety of reasons, there has been a gross underreporting of side effects across all psychosocial treatments, not just for ADHD. This became so glaring that in 2010, one of the leaders in the field of treatment of anxiety disorders, David Barlow, who has written several papers on this, reported in The American Psychologist that clinicians have to start paying attention to this. Clinical researchers need to document it because we will not figure out how to deal with these adverse events if nobody's reporting them. So what's causing them? What are the sources that they're arising from? How could we train clinicians to better adapt their treatments to these adverse events when they occur? It just isn't happening. Michael Linden in 2012 echoed this problem and also developed the first rating scale for adverse events in psychotherapy, which you will see here, the unwanted events and adverse treatment reaction scale. And he also went out and began promoting the idea that it is good clinical practice to monitor for adverse events, not bad practice, and that it is bad therapists who refuse to look or screen their patients, not the good ones. So trying to create sort of a reversal, what then was the zeitgeist within psychotherapy of simply not looking and not telling about your adverse events. It's even worse in ADHD. We don't see any reports of adverse events within our own field in the published literature until approximately 15 to 17 years ago, when I and my colleagues who were involved in a randomized trial of 3 psychotherapies for training parents of ADHD, oppositional, and conduct problem teens in problem solving and communication training, and we began to report adverse events, specifically deterioration among a subset of our families who were undergoing these 3 forms of therapies. This was followed shortly with a review article by Steve Evans on psychosocial treatments, one section of which he argues that we are ignoring the elephant in the room. We have as many adverse events probably as medications do, but we just don't talk about them, and we present our treatments as if they were benign, even if they're not necessarily effective. So there's very little in the literature, as my colleagues will attest to, on adverse events within ADHD psychosocial treatment, hence the motivation for this particular symposium. To me, as I have witnessed over the last 15 years, this creates a stunning hypocrisy among us, our colleagues, who publish in the literature. Why is that? Because routinely, medications and medication studies are required to report their adverse events as a routine part of publishing the results of their studies. This is not just for FDA submission. This is part of all journal submissions, all grant applications. If you intend to study a medication, a subset of your methodology has to be on the monitoring, systematic detection, and reporting of adverse events. We do not see that in our field. But what we read in almost every paper on psychosocial intervention is the author opens up with a straw man. ADHD medications have side effects. Therefore, we need non-medical interventions. Hence, ta-da, my paper, my study, my treatment, whatever it happens to be. Nowhere in there is it mentioned that, like medication, the psychosocial treatment being developed or under study probably has adverse events as well, but there is no intention of the clinician to even think about that. And I find this stupendously hypocritical. We cannot work with our colleagues in medicine if we ourselves are willing to ignore the things that they routinely are required to report in the use of their therapies for ADHD. So as you will see later, I have some recommendations on what we can do about that. But we have every reason to believe from the more than 50-year history of psychotherapy adverse events that we will see them in our treatments, whether we talk about them or not. Why would we get side effects? For these 4 reasons. First of all, there are variations across our clients that are staggering, not just in demographics or age or sex or personality and IQ and other factors, but also in comorbidity, particularly for ADHD among parents and other extended family. There is a lot going on in our patient population that would create such diversity, such heterogeneity, that there would have to be a subset that would react poorly to the standardized psychosocial treatment we are trying to apply to them. Even as long ago as the 1970s, I recall when I first came into the field, Robert Waller was talking about social isolation of mothers as not only a risk factor for oppositional disorder and aggression in children, but as a risk factor for failing in the behavioral parent training program that he and Jean Dumas and others had developed in parallel with Jerry Patterson for interventions for aggressive children. And it was as if he was speaking to a wall when he brought up these ideas that there were parent characteristics that would certainly pertain to adverse events or at least deterioration. We now know, thanks to the work of Andrea Kronos and others, that adult ADHD is a strong predictor of failure to respond to behavioral parent training, so much so that the recommendation now is that you don't start behavioral parent training with any parent who themselves has ADHD that is untreated. You treat the ADHD first, and then, as she has subsequently shown in her research, they will respond to the behavioral interventions that you are trying to do. But aside from these rare voices in the field, little is said about these client variables. There are, of course, therapy variables that have to do with choosing the wrong treatment for the wrong individual. I'll have a few words about that in a moment. As well as the method of delivering the treatment. Just 2 weeks ago, a paper was published comparing telepsychiatry parent training for ADHD versus in-session, in-clinic therapy. Turned out, luckily, both were found to be equally efficacious, but families much preferred the in-clinic face-to-face delivery of the intervention. And had you not assessed the families for acceptability of the treatment, you might have assumed that both treatments were equivalent across the board. They might be equivalent in effectiveness, but not necessarily in acceptability. There are, of course, therapist variables about which I will have more to say, and then I speak from personal experience when I tell you that sometimes you get caught in the crossfire of shifting cultural sands and the conflicts that they can create. As one who started out with Defiant Children, a behavioral parent training program for ODD and ADHD children, in which we initially taught spanking to parents as a means of backing up timeout should children refuse to stay in timeout, which was, of course, consistent with Connie Hamp's program from which this program sprang. It turned out that on the second edition of the program, we had to remove that because of changes going on in Canada, specifically, that were leaking into the US, that were now viewing any physical contact with that child to be a form of not only corporal punishment, but unethical practice. And so we rapidly had to develop an alternative to what was then a procedure that had been used for 25 years with families of defiant children in teaching them how to back up their timeout should a child refuse to remain in the timeout location. I know you're all shocked, but you make my point through your reaction to this, and that is I can honestly tell you back in the 70s, this was not an issue at all. But it became one in the 1980s as a result of changes in the cultural and historical context of the time. So I'm going to focus now a little more specifically on behavioral parent training and to some extent behavioral family training, which is what we do with teenagers. And first of all, point out that there, as I've said before, are almost no reports in the literature of adverse events. And I think this has to do with the fact that we don't have systematic tools, we don't have rating scales, we don't have standardized clinical observations or even lab measures that might get a handle on what these might be. We also have the glaring lack in most treatment studies of the reporting of individual change statistics, which many of us have been trying to promote in our psychotherapy, psychosocial treatment research. So you don't just report the results of your study at the group level, comparing means. You apply appropriate statistics like the reliable change indices developed by Jacobson and Truex, in which you calculate what percentage of your group improved or worsened reliably, taking into account the unreliability of the measure you're using as your endpoint. Are they reliably improved or not? You don't just pull some figure out of thin air like a 20% improvement on the Conners adult rating scale. That's purely arbitrary. It doesn't take into account reliability or unreliability of measurement. These statistics do. And when we started applying them in our research, as you will see, we began to show deterioration in a subset of our families that would have been completely overlooked in the reporting of group comparisons, as we often do in our journal articles. So a second problem isn't simply the lack of methods, it's the lack of appropriate statistics being used on our treatment research findings in order to be able to detect deterioration, at least, even if we don't detect new unwanted adverse events. And those are the two sorts of things we need to focus on. There are two forms of adverse events. The client gets worse on what you're intending to treat, in this case ADHD or oppositional behavior. And secondly, there is the onset of new unwanted adverse events that are detrimental to the individual that are not part of the treatment endpoint measurement, but nonetheless are occurring as a result of your treatment. I would argue that for behavioral parent training and family training, you can multiply this times 2 or times 3, because we not only have the patient, we have the parent, we have a mother, we have a father, we have a teen. So it's not just what may be happening to the child in its treatment endpoint, but what are happening to the people who are participating in the treatment as well. Specifically, the parents may be deteriorating. The parents may have adverse events that are developing. Case in point. This is the result of our studies in behavioral parent training initially. Thanks to Arthur Anastopoulos and others for their research in this area with my program. But here we see behavioral parent training, on average, improves about 64 to 75% of families of young children report reliable improvement in the treatment endpoints. In these studies, by the way, the treatment endpoints are defiance, parent-child conflict, parent sense of competence, parents' use of the skills while they are at home, and a decline in aggressive child behavior. ADHD is not really the endpoint of family or behavior management training. It's conflict. Most of these treatments were not designed to reduce ADHD symptoms specifically. They were designed to improve compliance and reduce defiance. And it's only been very recently that we've seen the development of programs like the New Force program in England that may be specifically targeted to ADHD. But all behavioral parent training programs are aimed at conflict, defiance, aggression, and a reduction in those symptoms. Now notice when we get to teens, we find what Jerry Patterson reported 40 years ago. There is an age-related response to behavioral parent training programs, such that the older the client becomes, and especially at age 12 to 14, there is a marked fall-off in the response rates of families to these interventions. And yet people blithely go on assuming that the 65 to 75% response rate applies to these individuals. It clearly does not. And as you will see here, we documented 7 to 15% of our families reliably deteriorated on the endpoints as a consequence of these interventions. And it was even worse when we move up to dealing with teens with ADHD in a family therapy sort of program. Here I'm speaking specifically of Arthur Robbins' program, Problem Solving and Communication Training, with Sharon Foster, which Art and I adapted and then combined with my form of behavioral parent training to study the combination versus either treatment alone. You will see here that our response rate, very similar to Patterson, is roughly 20 to 30% of families improve. The rest go nowhere, and please notice 6 to 23% of parents report deterioration on the treatment endpoint. This is reliable deterioration as a function of those interventions. Families get worse. And you know, it doesn't take a genius to see why. You're dealing with highly disruptive youth, and you're teaching parents to set limits on their non-compliant, defiant, and rule-breaking behavior. And just about anybody who understands behavioral interventions would know that at the moment you begin to confront this kind of misconduct and you withdraw positive attention for it, you get a post-extinction burst. And that is indeed what we were getting here. Here are all of the adverse events that we were finding in our behavioral parent training program, and especially in our adolescent family therapy program, that we had clinicians reporting back to us. We weren't using a rating scale. This was just routine weekly reports in our reviews of our randomized controlled trial. But you can see it is extensive, including violence on the part of these conduct problem teenagers against their parents, among other things. So there's a whole array of new, unwanted, harmful, detrimental events that have been taking place in these therapies but never make it into the journal articles. And again, I will point out, this goes back to Patterson's work with juvenile delinquents, in which he was also reporting very similar events. My colleagues, Carla Allen and Anil Chacko, took the typology of Dugan and applied it to behavioral parent training, saying there are 3 sources from which these side effects are probably arising. Number 1, you've chosen the wrong treatment for this individual, and as a consequence of that, you are producing at least 3 harms to the child and family that come from postponing the implementation of the effective intervention while you will go about applying the wrong intervention for the wrong problem. Now, you may think this is hypothetical, but allow me to point out that in 2016, the CDC held a press conference in which they bemoaned the rise in prescriptions for preschoolers with ADHD and took us all to task for not applying behavioral parent training as the first intervention for preschool ADHD before ever thinking of writing a prescription for these individuals. And the CDC proclaimed at the press conference that behavioral parent training was A, equally as effective as medication, which of course is false. It's not even 1/4 as effective as medication, and B, that behavioral parent training had no side effects. Well, as we all know, that, of course, is ridiculous. And yet here we have a government agency promoted with helping us with our practice guidelines to some extent, or at least giving us evidence to help with our guidelines, making what turned out to be some very foolish statements. But now what do we have? We have clinicians applying an ineffective therapy for ADHD preschoolers, withholding the effective therapy, all in the belief that this is good ethical practice, when it turns out to be absurd, in my opinion, for those of us who know and do behavioral parent training. Indeed, the preschool PAT study found that if you followed that procedure, only 1 in 4 ADHD children would be sufficiently improved not to take medication. 75% of the children in that trial were moved on into the medication trial because of the ineffectiveness of the behavioral intervention that was being used first. So as they point out, the second source of our adverse events will be the inappropriate application by the therapist of the legitimate treatment. So it's an appropriate treatment, but it's inappropriately applied to this individual. And there are a variety of reasons that I will not spend much time on because I'm running out of time here. But just to point out to you, there are many reasons for that that have to do with therapist training, therapist skill, technique, good listening, monitoring side effects, learning how to adjust the treatment if side effects arise, none of which clinicians are getting on a routine, systematic basis in their own clinical training. So we wind up with lots of problems here, including the failure to warn families about this post-extinction burst when you move into the limit-setting portions of the psychosocial intervention. And then, of course, there are the adverse events that are going to come out of the characteristics of the people you're dealing with, and that has to do with a variety of parent characteristics that in and of themselves are going to increase harmful events. Bill Pelham has shown that parents of ADHD children, when faced with an increase in defiant behavior, drink more alcohol. This has now been replicated. We also know that families that have depression get worse in reporting their depression and also become much more irritable and too quick to drift toward punishment, a finding, by the way, also found by Jerry Patterson 40 years ago. Parents drift to punishment, especially if they have an affective disorder. These are the kinds of side effects you might expect to come out of child characteristics. What do you think is going to happen if you set limits on a bipolar child, a psychopathic child, a highly emotionally volatile or abusive child, one who has already been trained in the use of physical violence through this coercive family process that Patterson talked about? You would expect to see a marked increase in destructive and violent behavior within that family. Yet therapists fail to forewarn this subset of families that maybe we shouldn't go there, or if we do, we're going to have to monitor this child particularly closely. And then, of course, there are a few other adverse events that Alan and Chaco didn't talk about that with regard to the application of teen therapies, and especially adverse events for the therapists. And having spent 8 years studying this family therapy in 2 federal grants, I can tell you that at the end of the 8 years, the clinic staff came to me and said, please do not renew these grants. Seriously, do not renew the grants. We're not interested in doing this anymore. We are burned out, which was a problem that Patterson reported long ago, that there is so little improvement in these families that therapists don't get the reinforcement they need for working with high multi-problem delinquent ADHD aggressive families. We had destruction of property, we had theft of possessions, we had fighting in the waiting room, we had to call the police into the parking lot because we were provoking discussions of problems within the session that were carrying over after the session as the family was leaving. None of this gets mentioned in the articles. Then there is the issue of how much improvement should we expect relative to deterioration before we declare treatment ineffective or perhaps harmful. At what point in this risk-benefit analysis do we draw the line and say maybe we shouldn't go there? Case in point, here's our family therapy grant. Please take a look. Structural family therapy, we had only 5 to 10% of the people improving. But across the groups, we had 17 to 35% of our families deteriorating, 4 to 23% deteriorating as a result of that. So look at the difference in the statistics. 17 to 35% improve, just as many deteriorated. What should we be recommending for the use of behavioral family therapy for ADHD teenagers. Should we go ahead? Should we blithely recommend this? I don't know. My point is to simply raise this with you in hopes that you will begin to focus on these in your own practice as well as in your own research. So to wrap it up, evidence-based behavioral parent training and family therapy are effective for subsets, indeed for behavioral parent training, significant subsets of the patient population to whom we are applying them. Keeping in mind, of course, that routine behavioral parent training is for oppositional behavior and defiance, not so much for ADHD symptoms, for which we get very weak and inconsistent, if any, effects in the endpoint. Second, we need to recognize that a subset of our families are actually deteriorating in a reliable way as a result of what we're doing, and that new and harmful events are being created that we may not necessarily be aware of if we don't monitor our patients in a more systematic way. We need clinicians who do research to develop more standardized methods like rating scales to help us track these adverse events, and we need to require closer monitoring of these events and reporting of these events. And I think the fastest way to do that is no grant should ever be given for a psychosocial treatment if it does not include methodology for the monitoring of adverse events in the patients being randomized in that trial, and no journal should accept any article on a psychosocial treatment that does not report its adverse events. We do this for medication. You would never get an article on an ADHD medication into a journal without a subsection of that results section reporting on adverse events. I think we have to do the same thing for behavioral parent training and for family training, among other interventions. We have to teach clinicians how inaccurate they are in detecting these events and why they, more than anyone, need to monitor these events and then adjust their treatments accordingly as they come upon these adverse events. Thank you very much. I appreciate your attention to my presentation. I'm now going to call up, thank you. No, all right. Thanks. By the way, I did forget to mention that we're holding all questions till the end so we can have a longer Q&A and not penalize the later presenters by running over. So at this point, I'm going to introduce my longtime colleague and good friend, Linda Pfeifner, who has been an expert in classroom management of ADHD for decades, and she's going to speak to us about the adverse events of classroom management.
Thank you. Well, I was happy to be invited to participate.
Not everybody is, shall I say, brave enough to do that and help us all to learn from that. So I'm very appreciative.
Yeah, thanks. I'm known as the Bambino Provocateur here at APSARD, and always willing to bring up the controversial topics. That's Italian for defiant child, by the way. Yeah.
Just a few random thoughts and or observations, I guess, most apropos to what Dr. Pfeifner was discussing. With respect to group contingencies, I've found that to be most useful in the not uncommon situation. It's the other kids, whether it's siblings or classmates, who are provoking our pal, who's our patient, or our student, and so on. And it kind of disincentivizes the pushing that kid's buttons. Perhaps a bit related to that, for the older kids, it's always a challenge when so much of the gratification or what's maintaining a disruptive behavior is the approval and encouragement of peers. Kids will be willing to put up with, with all kinds of consequences that authority figures can deliver if it gets a rise out of everybody else and rises their esteem. So, or they're standing within the peer group. So that's often something that we have to finesse in the context of what classroom behavior management and that sort of thing, I think. And finally, I've never been a big fan of daily report cards. First of all, I think I have a personally a little bit of an ethical issue about it. If I had a crappy day at work, I don't know that I want to go home, and if I, and Steve Plisco, will call my wife and say, well, Joe didn't, he didn't finish all his notes on time, and so on. Please don't, and that. whatever I like doing at home might be withheld. But apart from that, you also put parents in a tough bind where things might be going swimmingly at home after a lousy day at school, and now they're in the position, or at least the expectation, that they're the ones who are delivering a consequence from relative to events that happened some hours earlier. So the contingency chain is sort of broken, in my opinion, and it's not related necessarily to what's going on at the moment. You know, if you want to have rewards, the kid had a great day, got everything done, and he gets something extra special, then that's great. Sometimes teachers use these things just to communicate about how the day went. That's great, but if you can avoid putting the parent in that bind, I advocate for that.
Thank you very much for those sage observations, clinical anecdotes. They're more commentary than question, but we'll see if there's some reaction from the panel.
Yeah. In terms of the first point you made about the group rewards, that's kind of like a positive side effect of group rewards, which I agree that we can see that. And the concerns around the daily report card are interesting because you brought up an additional potential negative effect, which would be on the parents for pulling them into the whole thing. And in some of those cases, we use school-based rewards. If it looks like involving the parents wouldn't be a good thing. However, in some other cases, it's interesting because I think that it's a little more complicated. The whole story is a little bit more complicated because teachers often feel more empowered if the parents are involved, and we hear that all the time. Most of the work I conduct involves the group of teacher, parent, student, everybody working together, working towards similar goals, trying to make sure everybody's on the same page. And part of the impact that I see happen, but we really need to do a better job measuring this, because just my hypothesis is that the teachers are more motivated to adhere to the program and to put their best effort into it if they feel like everybody's in it together and if the parents are involved and also helping. And on satisfaction measures after our treatments, often the teachers show the least amount of satisfaction in cases where parents were not involved in the program. So I'll just put that out there, although your point's well taken for sure.
Indeed, indeed. We'll go over here for a question.
Thank you. So my question is addressed to all of you. So in looking at a lot of the early literature on effectiveness of psychotherapy, some findings that I saw were that regardless of the modality, some of the most important elements were really the skillfulness of the practitioner, and maybe even more importantly, the rapport or the relationship or therapeutic alliance between the therapist and the client. So there's one thing I want to know if you've seen that in the studies and if you would think those would be good things to assess and monitor. And then the other piece is the readiness of the client or patient to engage in the practice in the first place, and then their ability to make the changes. I know these are different confounding factors. It takes longer for certain people than others to make good use of whatever the modality is.
Mm-hmm. No, both important, Laura. I don't know if you have any reaction to.
Yeah, I can't recall off the top of my head whether I've seen any studies that have, I mean, there's certainly systematic measures of the quality of the therapeutic relationship, and I think that would be absolutely critical to measure. I think, sometimes CBT gets this rap as being, just do this, and, in order to get people to make these difficult behavior changes, you really do need really good rapport. You need to be tuned into your client to know when to shift strategy. So I think that'd be great to measure. And then, the stages of change question, too, would be a really interesting thing to measure as a moderator. I think that's great.
Yeah, I think along with that, one of the points that several of us have made, specifically in my presentation, is the idea that the clinician is not always the best judge of what is going wrong and when it's going wrong in therapy. So it's a little hard for them to stop at that point if they themselves have no sense that there has been deterioration, or the patient is reluctant to share the deterioration for fear of perhaps offending the clinician. Whatever the reason is, we've known, going back to Paul Meehl's work on the flaws of expert opinion, and Danny Kahneman's work in behavioral economics on the cognitive biases of experts that make them no better than lay people in making judgments about their field or some process or some outcome. And we can see that applies to not just psychotherapy generally, but ADHD intervention specifically. I think one way we might get around that and maybe address even some of your concerns is by training clinicians to formally monitor patient reactions and not wait for them to spontaneously volunteer what the side effect might be, might help us to get around that limitation of clinician judgment, because it's just a routine part of what we do, is we not only monitor progress, which behavioral people are known to do, but we want to be monitoring side effects systematically. And it might bring it to their attention, especially if they've warned the client that we will periodically be assessing your distress, so that they don't feel like they're somehow impugning your reputation or sabotaging the intervention by complaining about something that's going wrong. And I think that could be extended to the 2 points you made as well. Because my concern right now is that clinicians just aren't aware that this is happening. If they care, it might be a blame the victim. It's their problem, not mine. They're not bringing it up. And then they're just not monitoring. So maybe we could do something about that. Thank you so much for bringing that up. We'll go to this microphone.
Thank you. First, I want to say I really appreciate what you're saying, Russ, about the implementing adverse events. I think into research, that makes so much sense. I think that's so necessary.
I'm tired of being a hypocrite when I do psychosocial studies and my medical colleagues have to monitor adverse events. I mean, it just doesn't make any sense.
Right, and as a couples therapist, I know what an adverse event looks like, and I think it's horrible if therapists don't know what their adverse events, what they're doing, if they're causing more damage than good.
Sometimes.
Yeah. So I have first a question and a comment to Linda. Are these CBMs applied to just children where they're identified as being the problems, or is it to the entire class? Because I can see that could be in and of itself a problem. And my comment is, I feel that no program is going to work very well unless there's a congruent, real-time, relational approach that deals with the way a child is trying to attempt to understand why, from the child's point of view, they're not buying into what the teacher is wanting or is attempting to do. You know, and for Laura, I'm just wondering, how do you judge symptom reduction when clients don't come in to reduce symptoms? ADD clients are all different, and one person's trying to save their job, and another is trying to manage their time and in order to reach a goal that they never can seem to follow, and a third person's trying to stop feeling like a total screw up and a failure all the time. How do you deal with? How do you measure that?
Three good questions. So the first two for Linda. Don't leave the mic because we might not remember them. My working memory.
Sorry.
I didn't really hear it.
Well, the first one is, are your interventions being applied to ADHD specifically, or to the whole classroom generally, ADHD, non-ADHD, in these CBMs that you're doing?
Yeah, so some of the practices, as you could tell, are good for all students, right? So you've got some really excellent teachers out there that are doing everything right. And in fact, they don't maybe have to do, a lot of extra things for their children who have particular attention behavior concerns, because the management program is pretty tight and structured and predictable and et cetera, just along with what I said. There are certainly some cases where we're focusing more on the student with ADHD, and maybe more, it's actually, I haven't thought about this exactly before you're saying that, but it may be that we need to come in with something more intensive for that student with ADHD when it's a sort of chaotic classroom environment.
Yeah.
So everything's done in context, right? So it might have to, that's something we need to consider. For sure.
I think the second question had more to do with, was it the client buying in, the child in this case,
kids buying
into the goal of the intervention? It's been defined from on high that this is our goal and this is what you need to be doing. But what about, especially for me with teens, if they don't own that goal, and they don't see that as part of where they want their life to go, it starts to become a real struggle, and some of the side effects literally can arise around the tension.
Yeah, and also I've worked more
with
school age, but I say that's a really excellent point, and you have to consider both it on the level of the teacher, as well as the parent, as well as the student. And so in setting up any of these programs, I view that it needs to be a very collaborative endeavor, and so that you don't go in with established target behaviors. You have ideas what might be appropriate to focus on, but you really involve the teacher in selecting those based on what they see. And the rewards. We know from one of the first slides I showed you in the research we've done that child choice is a huge factor in whether it's going to be effective or not. So rather than just saying, here's the reward you earn, it's really bringing the child into the process. So you could say that at every level, you really want this to be more of a collaborative rather than a really, top-down approach. So it's a good point.
And I would say that goes up to an even higher level of buy-in to the disorder, not just to the specific goal we're doing. And for teens and adults, as Laura and I sometimes talk about, that is a major issue. If you are not aware of it, Adam Levine created a video for Shire that's over on YouTube called Own It. And that is his point, that no therapy for any specific goal or target is going to be any good if you don't see yourself as having this condition. It's like trying to treat a diabetic who denies that they're a diabetic. And so if you're not aware of that video, we have found his presentation to be very convincing. He's major adult ADHD, and yet views it as simply, this is part of who I am, and I learn to manage it in the places where I need to manage it. So I would direct you to that
Adam
video
Levine.
to help with that. If you're not familiar with him, he's on The Voice, he's part of Maroon 5, and he's a major player these days in pop culture as well. We'll be singing at the Super Bowl, I understand. So, just a little plug for Adam for all of his work that he's done for adult ADHD.
Thriving
Laura?
and functioning, clearly.
What's that?
Thriving and functioning, clearly.
Yeah, that's right. And then part of the question was
Yeah,
directed
thank you for the question about what are you monitoring and how are you monitoring on an ongoing basis? Yeah. So the approach that I was trained in, which is Steve Safran's Mastering Your Adult ADHD, we would do the adult ADHD rating scale at the beginning of each session and have a conversation with the client about it. And I used to frame it as, I'm not a physician, so I can't take your blood pressure or your temperature. Like, this is as close I can get. But then also to, throughout the frame of therapy, come up with a kind of longer term goal. So I remember one of my clients, it was filing his taxes on time for the first time in like 10 years. And that was a really good thing for him to apply his skills to. So if you can kind of come up with a concrete goal like that. Another thing I've started doing more now is using checklists of the actual skills that are included in the program as an ongoing measure. Yeah, that's something, and I know Mary Salanto has the OTMP, that's a measure that you could use.
Nice.
Those are just some suggestions.
Yeah, very
Thank
good.
you.
Thank you so much. We'll go to this microphone in our alternating sequence.
Thank you so much for this presentation. I'm a master's in social work student, and it's my last semester. And this is the first presentation I've ever heard on adverse events in therapeutic treatment in
Hallelujah,
my
right?
entire career. The only time I've heard of it spoken about is with EMDR, and those are always spoken about short term. So I think my first question, I have two, is Dr. Barkley, why are we not talking about this in the wider therapeutic world?
Well, I listed a couple of reasons that other people have suggested over the course of the last 50 years. The first being is the perception, both outside the field and in the field, that we're not all that effective at what we do, especially when there are medical alternatives that are resoundingly more effective. I think that's changed since the advert of behavioral and CBT and related DBT, that sort of thing. We've become more relevant than we were when we were just doing general psychotherapy. And as a result, we've seen more reports of adverse events coming out that probably weren't that way. The second thing I reported is that clinician bias against even thinking about, detecting, or monitoring these effects is a profound problem that we have in our field. And of course, you have the experts say, well, I don't have any patients with, who have these kinds of side effects. I don't know what you're talking about. When in fact, as we saw, between 10 and 24% of their clients are getting worse. They just don't know it. So I think that's a second problem, is the clinician blinders are on with regard to adverse events. And I think the third, as I said, is that it has not become a matter of course or protocol within our field, as it has in psychopharmacology, that this is a routine part of what you do. And if you don't, it's negligence. For a clinician not to monitor side effects after giving a prescription is negligence. And yet we just get a free pass, and yet we want to be as relevant as they are, and we want to set up our articles as if their side effects are our motivation for doing what we do, but we don't want to play by the same rules when it comes to monitoring disclosure of adverse events and so on. So I think that's got to change. Hopefully it will change willfully through programs like this and articles like the kind my colleagues have written on the topic. But I also know that fields don't move willingly. They often progress by death of older members and replacement by younger members who are more receptive to the change. Even Thomas Kuhn talked about scientific paradigms change through death. Just look at the cemetery, we'll know how quickly your paradigm is changing. And so sometimes what has to happen is a requirement has to come down from on high to the guild, to the mental health professionals saying, you have to do this. It's either part of practice guidelines, or as I argued, it needs to be part of grants, it needs to be part of journal acceptance. And let me tell you, things will change so fast because those are the gateways to your career, to your development, to your promotion, and to your funding. And that may have to be the route that we have to go. It's unfortunate that it has to be external pressure, but we all know that ADHD in our public domain has advanced not because of our field. It's advanced because of the pressure that was brought by parent support groups from outside on the field to get with the program and start doing better servicing and access to care and so on. And sometimes we need to be prodded to change where we don't change ourselves very easily. So,
A quick follow-up question
Yes.
for Dr. Naus. Kind of a two-part question. What do you think are the next steps for sort of streamlining CBT for ADHD? And then kind of a side question is, do you think that those who have ADHD who go through regular CBT protocols can experience more pronounced adverse effects from that?
Can I clarify the second question?
Yeah. So if someone is either undiagnosed or going to a non-specialist.
Oh, I see. So if the ADHD is part of it, but it's not being addressed by the treatment.
It's just regular CBT for maybe depression or anxiety or something else. Do you think that that can ever be harmful? Or
Again, I don't have a lot of empirical evidence, but I would say I could see where that would be the case. I mean, we have a little bit, there are a few papers around when the first chart review study of CBT for adult ADHD came out. I'm blanking on the name of the author, but who were looking at patients who came in and got diagnosed as adults, but who had already been through routine psychotherapy and had adverse events related to, say, their symptoms being interpreted as resistance or kind of inappropriate, sort of insight-oriented processes being applied to what really are executive.
so there are a few studies out there on that?
Yeah,
Look that up.
probably Dr. Ramsey. two people
ask him
back
later.
could tell you.
Go, which one?
I think it was John Rady and colleagues.
That's it, yeah.
Yeah.
Thank you.
Awesome, thank you. So, and then what do you think are the next steps for creating streamlined CBT for
I have
ADHD?
so many ideas, but none of them that I'm really confident in, but I'll put out a few. I would love to see a lot of collaborations across groups that have tested different iterations of CBT. I think it would be really exciting for us to all put our heads together and say, okay, if we were on a desert island and had to treat ADHD, or let's say we only had 4 sessions to treat ADHD, what would be the first thing we would start with? And maybe do one of these, what I'm trying to call sort of an assembling study to see what might be the most effective. I don't know exactly how to do that, but that's one idea.
Good
Thank you.
question, though. Thank you so much. Oh, over here, Margaret.
What do we know about adverse effects of therapy on family variables such as marital conflict? I've seen parents asked to be consistent with each other when that's simply impossible, and disengagement. I've seen transfer of symptoms to other siblings, changes in sibling relationships, scapegoating, and one of the difficulties there is it's not always someone who's an identified patient who is showing the adverse event. So I'd like to know what we know about that, and then as a second question, how are we ever going to measure that?
Well, the answer to the first question is easy, nothing, because I've sort of reported to you the very few papers. I'm talking about ADHD and psychosocial intervention. If you move outside of ADHD to family work that's been going on with conduct disorder, going all the way back to Jerry Patterson and the Oregon Research Institute, you know, they certainly were reporting more anecdotal than systematic difficulties that were arising in the family, and I reported a few of them. Unfortunately, I had to go through the slides very quickly about, parents who may be depressed getting worse, marital conflict goes up in maritally fragile families that you're working with. You have teens confronting one parent more than another. So there may be, as Art Robin talks about, some triangulation by the teen going on in the family of playing parents against each other within the program that you're trying to implement. But everything I'm saying is anecdotal from the people who delivered the service as part of the grant or the study. It doesn't make it into any measures. It rarely makes it into the papers. So we don't know. This is what we need to know more about, but we won't, as Barlow pointed out, if we don't even look.
So if we create a MEDRA of, in other words, a classification of adverse events for psychotherapy,
Yeah.
how are we going to address those in people who are not our identified patient?
Yeah, well, it's a good point. I mean, persuasion is one, pressure from outside is another. I think you're talking about monitoring as part of their therapy program. Practice guidelines become a way of trying to get some of these ideas implemented into practice. So unless I misunderstood the question, I think.
The question is that sometimes the adverse event
Yes.
is not the patient in your
Oh, I thought it was the last question. No, that's true. That was your second question.
If it's not the patient in your room,
Right.
how do you get at the effect that is otherwise unseen and change the process?
Yeah, and that's it. Change the process. So, but all good points. I mean, we are that early in the identification of these events and the study of these events that we just don't know these things. All the reason to look. I mean, there is a program of research that could occupy a career within this area alone, and hopefully some young Turk will take it on as their mission to do that. Thank you, Margaret. Yes, over here.
Hi, my name is Aaron Winkler. I'm a PGY3 psych resident at University of Maryland, Shepherd
Yeah,
Pratt.
welcome, Aaron.
I have two questions. Thank you. This is fantastic and very helpful. And yes, we definitely focus on adverse events a lot when we're giving out meds. We're expected to ask about it in absolutely every session and list it in our notes every single time. No adverse effects no adverse medication effects. Every single progress. Every time you see anyone, you have to talk about that, not even just in research, but in clinical care. Which makes me now think that I do ask that every single time, but here I am as a third-year resident doing dynamic, insight-oriented therapies, which, as you said it occurs to me, sort of all focus on getting people to own it, sort of like the whole endpoint. And I am checking to see if they're having adverse side effects to the meds I'm giving them, and I'm not asking them to give me adverse side effects to the therapy I'm giving them, which we know happen. I mean, somebody goes through true dynamic insight therapy, there's gonna be a crash where their whole life gets switched around. If you're doing it well, that's what ends up happening.
Yeah.
And so I have two questions that hopefully both have very short answers for everyone else's benefit. Dr. Noose, if I want to do that, if I want to have somebody fill out something like a PHQ-9, but better than that, every time they come in, what should I use? And then my other question is for Dr. Pfiffner. Totally unrelated, I have 3-year-old twins, and I find myself drifting to punishment. And I've read a number of the sort of pop press-oriented how to do disciplines things. Your presentation was so much more helpful than all of those books, and I'm wondering if there's anywhere that just that really dense play-by-play is available, because it's so much better than I dig through, a chapter that's so much fluff to get to the one, okay, so extinction may not be right here, right? Yes.
Two good questions. We'll start, Laura. The first was for you. I don't know about measurement of side effects. Do you recommend some tool like Linden's scale or some of the others?
Linden's scale, I think, is only a structured interview, so I don't think you could use that kind of as a temperature taking. The other one that I saw there that I didn't really investigate in detail, I believe is a self-report. And if you give me a moment, I'll look up the name.
Yeah, because if you, I would think it would be relevant to all of this. If there's a way we could do, just like every time somebody comes in, we're going to just fill this out, and that's going to give us our adverse events check. I don't know if that exists.
But
It would be very helpful.
before we get to the second question, I'll just go back and just give you a little historical note here.
Thank you.
The most commonly used side effect rating scale for stimulants in research is our side effects rating scale, which was created in less than an hour by sitting down with my child neurology and pediatric colleagues who were writing the prescriptions and monitoring the kids, plus the research staff that was involved in studying drug effects, and literally generating off the top of our head in a brainstorming session every possible event you could think of that you might attribute to that, and then putting it in a scale. So we came up with these 18 items, rated them on a scale of 0 to 10, and started that way. And then our colleagues picked it up, and research articles got done, and we started to get data. We started to realize that some were pre-existing, and that's why Laura's comment about you need to take these before the therapy, not just during the therapy, or I think, Linda, you pointed out they can be pre-existing symptoms and not real symptoms. Many of the side effects attributed to methylphenidate and amphetamine are pre-existing conditions, and when you do blinded and placebo assessments, that it shows up as maybe 4 or 5 rather than 18. So I think somebody just needs to sit down for an afternoon. Can we brainstorm this a little bit? I mean, the commonalities across these 3 presentations, particularly between Linda's and mine, over what we were seeing in response to behavioral interventions is pretty, I think, reassuring that you could develop that kind of an instrument for behavioral interventions fairly quickly, and then put it out there. Let
Yeah,
people start to
I
use
may
it.
do that with my supervisor back at Shepherd.
Yeah.
That's probably what, yeah.
Okay. The second question,
Remind
Oh,
me
but
the
Dr. Krause was about to answer
Oh,
the,
I
Oh.
found.
sorry.
It's the Experiences of Therapy Questionnaire,
thank you.
Parker and Colleagues, 2013.
Okay. Sorry about that, Laura. Yeah, the second question had to do with resources that you might recommend that kind of pithily get to all the points you were making in your
Well,
talk.
that's a good
Your book
point.
being one of them, by the way.
So I have a book for classroom teachers that is pretty basic. I mean, it's easy to read, and there might be some transfer, even though your kids are 3, right? They could be I was thinking they could be the N of 2 group reward group.
It is very interesting because they're very, very different and yet exactly the same age, boy and girl. But I'm sorry, I was writing down Parker and Colleagues and I missed the title of
Your book.
Oh, all about ADHD. It's a complete guide for complete
teachers.
practical guide for classroom teachers. It's a scholastic book. Again, it's written for teachers of school-age kids, but there'll be some ideas in there that are just like what I discussed, right?
And it's
if you
on
ever
Amazon.
make
Yeah.
If you ever make a really condensed version of those slides, I would love to see that.
Oh, sure.
and I'll
That's
put in
not
a-
a problem. Yeah, not a problem.
I'll shamelessly put in a plug for my new book, which is Managing ADHD in School, which has 80 recommendations for teachers that are evidence-based to implement in the school system for ADHD children. So it's even more pithy than...
How about one for preschoolers? Was there one?
There's a preschool parent training program that was developed by Lisa Arnold at the University of Massachusetts, which you can find on Amazon. It is the preschool equivalent of my Defiant Child
Okay.
book,
Yeah.
but specifically for ADHD
Okay.
preschoolers. So
Yeah.
that's the only preschool manual I'm aware
Yeah,
of in
okay,
existence.
okay.
And in terms of dynamic psychotherapy, the line I thought of was from the show In Treatment, where the therapist Gabriel Byrne said, "Psychotherapy is the only business where the customer is always wrong."
That's right. Yeah, let's victimize the victim,
Right,
right?
right.
Yeah.
No, my question, and Dr. Naus, you might want to just talk this over later because I know we're over time, but the thing that strikes me about these treatments using Steve Ferrone and Kevin Anschel's broadband versus narrowband, like medications are a broadband treatment, you target the symptoms and then you have impairment improvement. What do you think we are treating in CBT? What do you think are some of the active ingredients? I mean, even this is conjecture, I know, but I respect your opinion.
Well, certainly, as you've written about compensatory behaviors that we're using to help clients work around those symptoms, I think especially ones that involve setting up the environment in ways that are going to cue appropriate behaviors, kind of building on Dr. Barkley's work on sort of using the environment, offloading cognitive load onto working memory aids, using the social environment. I think I actually had one of my students, I teach an ADHD senior seminar, and I had one of my students write their response paper on a chapter that I wrote, calling me out for not talking enough about the social environment in CBT, and I was like, you get an A automatically just for disagreeing with
Right,
me. And
very
she
good.
was right? So using the people in our lives that can help us be the better angels of our nature and cue those desirable behaviors. And then, of course, as we've talked about a lot, the cognitive pieces, whether that's negative automatic thoughts that are leading to avoidance or overly positive, optimistic thoughts that are cueing avoidance behaviors.
Right, because I really don't think, even though we use symptom measures, we're really not treating DSM-5 symptoms, at least in the CBT psychosocial. So I think that's on point. Well, thank you all very much. This was excellent.
Excellent point. Well, I want to thank all of you for your attention span and impulse control. Thank you so much. Good seeing you. Be well. Thank you. Great job.